Okay. Contemporary use of progestogens in recurrent and threatened miscarriage. Sorry, let us go back. At the bottom are my disclosures, but again, these do not have any impact on the content of this talk. I will discuss two subjects: threatened miscarriage and recurrent miscarriage. Now, here am I confused in some ways, because if we talk about progestogens in both types of miscarriage, let us ask three questions. Why should it work? Why does it often fail? And does it in fact work or not? Let's have a look. We'll start with why should it work? Now, the name progesterone was given in the 1930s, and what it means is pro, for, gest, pregnancy, steroid, own, ketone. The for pregnancy, steroid, ketone. Well, if that is true, what is it doing in animals like these who don't have pregnancies? Each of them, birds, reptiles, and amphibians, have progesterone. And indeed, even this animal, Brachionis, a one-celled, amoeba-like animal, has also been found to have the progesterone receptor and progesterone. Amazing. Well, let's have a look further. Of course, that would mean that this name, progesterone, is in fact a misnomer. Well, in evolution, this Brachionis had progesterone receptors at the dawn of evolution. And what was its action? It was an anti-inflammatory agent controlling the inflammatory response to foreign tissue of the foreign DNA which was introduced by the, should we call it, male, Brachionis, when it injected its DNA into the female in order to have sexual recombination. What does it do in these animals, in reptiles? Well, it induces the deposition of egg white proteins, the formation of the eggshell in the oviduct, and decreases myometrial contractility, decreases contractility in that part of the oviduct which allows delay for all of these extra layers to be put around the egg until the egg can be laid. And what does it do in these animals? Sorry to call them animals, but I think we are animals after all. This is supposed to represent a mammal. Okay, what did the mammals do? They adapted that action of the oviduct for the needs of pregnancy. There's the same delay in the oviduct, but in mammals, it allows the egg to develop into a fetus which is mature enough to live life externally. So they adapted that action and used the anti-inflammatory actions to allow the development of a semi-allogenic embryo. And I think we have to remember that point when we speak about progestogens in early pregnancy. Well, you know, progesterone still has its anti-inflammatory responses. Look at this picture of rheumatoid arthritis and look at this sketch of demyelination in multiple sclerosis. And we know that progesterone decreases the inflammatory effect in both of these diseases. Now, I know it has other effects in other diseases which are not dependent on the same mechanisms. However, these are actions of progesterone, and if you read the text, which I'm not going to read to you, it will show the various mechanisms by which progesterone may work on the anti-inflammatory effects. So, what does progesterone do in pregnancy? This is a list of its endocrine functions. Decidulization, implantation, it inhibits arachidonic acid release, reduces cervical stromal degradation, it reduces gap junction formation. Do you remember the gap junctions that develop late in pregnancy? Allowing the electrical signal to run from one myometrial cell to the other, enhancing the contractility, making labor easier. This is they did tell me that the mouse would show on all the screens. These are the gap junctions allowing the electric signal, and, of course, progesterone prevents that effect, and it decreases the number of oxytocin receptors. Well, that we know. We learnt that in medical school. We teach the students that. But what else does progesterone do? In pregnancy, we think there's a balance of two types of cytokine. Th1, the pro-inflammatory cytokines, and Th2, the anti-inflammatory cytokines. And without going too much into the immunology, this is progesterone's original role in evolution, that the T2 cytokines, or the Treg cells, protect pregnancy from an immune response. The Th1 and Th17 cytokines are associated with miscarriage, and we know, for example, TNF-alpha leads to thrombosis, activates natural killer cells, and so on. Well, okay. What are the immune functions of progesterone? Well, we know that in subfertility and amenorrhea, there are autoantibodies to progesterone and 17-hydroxyprogesterone. We know that progesterone affects cytokine release, decreases interferon, one of the Th1s, increases IL-10, one of the Th2s, in the endocervical fluid. It upregulates leukemia inhibitory factor, mRNA expression in vitro. It inhibits the activity of natural killer cells. Okay? It favors the production of asymmetric pregnancy-producing antibodies and induces the production of another cytokine, PIBF, progesterone-induced blocking factors. So there are a number of immune factors in addition to its endocrine function. Now, dihydrogesterone, as we've heard about before, has many similar effects. It inhibits interferon gamma. It increases two of the good Th2 cytokines, IL-4 and IL-6. Dihydrogesterone is blocked by mifepristone, indicating that it works on exactly the same progesterone receptor. It induces PIBF, and in preterm labor, dihydrogesterone is associated with higher serum levels of IL-10, increased PIBF, and lower concentrations of interferon than in controls. So dihydrogesterone seems to have similar effects to progesterone itself. But what's this PIBF? This is Petra Ark's work. On the left, you can see the graph showing that normally progressing pregnancies, women with normally progressing pregnancies, have higher levels of PIBF than women with spontaneous miscarriage. Okay? We know it's a cytokine produced by T lymphocytes. Its production rises with trophoblast invasion. It increases the production of IL-10 and IL-4. So PIBF is in some ways related to the anti-abortive effects of progesterone. Evidence. Well, many of us know Sapo's work back in the 1970s, in which he excised the corpus luteum of women at the beginning of pregnancy, and that was followed by abortion. That excision of the corpus luteum was responsible for a fall in progesterone levels. We know that the progesterone receptor agonist, mifepristone, blocks the progesterone receptor, causing fetal death and placental separation. We use it in order to induce artificial abortion. How many of us use mifepristone to induce artificial abortion? Come on, commit yourselves, raise your hands. Yes, I see many hands going up. Well, that's because of its anti-progesterogenic effects. Okay? So the defective corpus luteum may produce low levels of progesterone insufficient for ripening, implantation, or placentation. Now, having said why it should work, we've heard the theory, the immunology, the endocrinology, etc. Why does it often fail? You know very well that if you have a patient with miscarriages, you cannot give her progesterone and expect 100% live birth rate. Well, there can be confounding factors, or overwhelming of the immune response. Confounding factors. The upper picture shows a sonogram showing a missed abortion. The lower picture shows exactly the same thing, but by embryoscopy. Here you can see, if I can get it, the fetal head, the fetal hand, and can you see that the whole of the neural tube is open in one huge encephalous seal? This is from Tom Phillips' work in Austria. This is missed by ultrasound. So there are structural anomalies which we tend to miss. And these anomalies can be so severe that they're incompatible with life. We cannot expect progestogens to correct them. Embryonic aneuploidy. This is a genetic chip of 16 trisomy. Can you see this raise in the DNA level where chromosome 16 is found? Well, 45% of recurrent miscarriages are due to chromosomal aberrations. 16 trisomy, 1821 exo, and triploidy are always incompatible with life. There's never been an infant born alive with 16 trisomy. And none with triploid. Well, that's not true. There are 10 in the United States that even have a website of 10 families with triploid. That's 10 out of the whole human population, or at least of those that go to the internet. Okay? The others can be born alive, but very often end in miscarriage. They can confound the results of using progestogens. They can be overwhelming of the immune response. What I mean by overwhelming is if there's an infection, okay, the infection will lead to inflammation, release of inflammatory cytokines, such as IL-6, rupture of the membranes if it's in late pregnancy, uterine contractions. The effect of these cytokines from an infection or other factors will overwhelm the protective response, leading to, if you like, labour. And if that labour is very early in pregnancy, we'll call it miscarriage. If it's the second trimester, we'll call it miscarriage, and maybe some of those in the first trimester as well. So that's why it might not always work, because the results can be confounded. Well, does it work? That's our third question. Threatened miscarriage. Let's start with that. In 2011, Wahhabi of Saudi Arabia published a meta-analysis in the Cochrane database. He took what he found at that time, which were 4 studies looking at progestogens in threatened miscarriage. The 2 at the top used what they called oral progestogen. The oral progestogen in the text is described as dydrogesterone. El-Zibdi study and Pandion study. Both of those showed a trend to lowering the miscarriage rate, and if you look at the common odds ratio, you will see that that number is statistically significant. He found 2 articles at that time on vaginal progesterone versus placebo. Gerhardt, who used a vaginal preparation that he prepared himself, and Pagliano, who used micronized progesterone. Neither of these 2 were significant, and neither was the common odds ratio. When he put all 4 together, there was a significant effect, because the dydrogesterone, which had much larger numbers, 86 patients, 60 patients, 95 patients. The numbers were much larger than the 17 here, 25 and 25. So the 2 papers on dydrogesterone pulled the subsequent figures over into statistical significance. Absolute benefit, 12%. And that was statistically significant. That led to 2 guidelines. Now, the other 2 speakers here today Nick Panay, who is after me, is from the United Kingdom, and Rod Baber, who is before me, is from Australia. So what do their national societies say? Well, the NICE guideline in the UK, the National Institute for Health and Care Excellent, said that data from a meta-analysis suggests that progestogens are better than placebo. And then, as everybody says, we need more papers. Fine. Isn't that the standard code to say we need more papers? Okay. And the Royal Australian and New Zealand College said in 2013, miscarriage was significantly less likely to occur on progestins than progesterone. And they also said the evidence remains preliminary, we need more studies. Well, we do need more studies. So what did we do after that? In our own meta-analysis, which we tried to widen the figures in the Cochrane database, we went through the standard procedures of looking through the literature and sifting out all of the articles and so on. We found 23 articles, 5 were eligible for inclusion as randomized studies. And what did we see? Fixed effects model on dydrogesterone. Why dydrogesterone alone? Because we couldn't find any additional papers on vaginal progesterone at that time, and there were none on intramuscular progesterone. So we had to use dydrogesterone alone. And what do we see? Using those 5 papers, that there was a significant reduction in the miscarriage rate, which was statistically significant, or to put it another way, there was a 47% reduction in the odds of a pregnancy ending in miscarriage. Since then, there has been another paper on vaginal progesterone, YASI. So these are the 2 in the Cochrane database and YASI's paper together, and if you look at the 3 together now, they do still not reach statistical significance. Now, there is another study about to start, the PRISM study, progesterone in spontaneous miscarriage by Raj Rai's group and Mariette Godijn in the Netherlands. I don't know whether they've started, but they will pull the results one way or the other. But at the moment, on the 15th of March 2017, those are the results that we have at the moment. A certain type of miscarriage, retroplacental hematoma. Here you can see a sketch of the embryo in a retroplacental hematoma. Pelinescu study showing the effect of dydrogesterone reducing the chance of a retroplacental hematoma developing to miscarriage, and micronized progesterone. Okay? Relative risk 2.04, which was statistically significant. Now let's go to recurrent miscarriage. 3 consecutives in Europe, 2 consecutives in the United States or Russia, approximately 1% of women of childbearing age. The risk increases with maternal age and so on. Well, what happens there? This is a meta-analysis of all of the progestogens which have been used in recurrent miscarriage. This was drawn up for a recent book of mine. If you have a look, all of the progestogens, medroxyprogesterone acetate, 17-hydroxy, Levine study on an implant, all show an increased trend for a live birth rate. The 3 papers on dydrogesterone, these 3, Friedman, El-Zibte, and Kumar, were statistically significant. We now have a paper on micronized progesterone, only one, the PROMISE trial, which showed no significance, no difference in effect. And so the PROMISE trial is down here. There's another meta-analysis by Sacconi that went out just about a year ago. Again, all of the progestogens, he used a slightly different criteria to the ones that I used. And again, the 2 papers on dydrogesterone reduced down the incidence of a further miscarriage and recurrent miscarriage, whereas Kumasawari's trial, the PROMISE trial, is here with no significance. Overall, there was a significant effect in reducing the miscarriage rate. What was this PROMISE trial? It's an article that went out about 15 months ago. No, it's a bit more. October 2015 in the New England Journal of Medicine. Many of you will know this paper. What they did was they randomized women to have micronized progesterone or placebo, double-blind, placebo, randomized, everything that good evidence requires. 404 women treated, 432 placebos, an intention to treat analysis, 65% live births after progesterone, 63% in the placebo group. Of course, the results were almost identical. We did a meta-analysis on this as well, again, using the standard criteria before the PROMISE trial. 3 papers on dydrogesterone. At that time, there was no PROMISE trial available. And on those 3 papers, again, you can see there was a reduction in the miscarriage rate. Now, why should there be a difference between progesterone and dydrogesterone? Well, Rod Baber said this before in his previous lecture, but let me just sharpen the point a little. This shows bioavailability, adapted from Adolf Schindler's work and Stanford. Can you see that dydrogesterone is much more bioavailable than progesterone itself? Next one is receptor binding. Dydrogesterone binds the receptor 50% more than progesterone itself. That may explain the difference in the effect that we see between those 2 different progestogens. So, should progestogens be used? Here am I asking the question again. Should we use them or should we not? There are 2 approaches. One is the evidence-based approach, okay, which I'm not sure it's evidence-based, but this is what many people say, and say, if we don't know all of the confounding factors, we should analyze the results on a large intention-to-treat basis. And we rely on randomization to put the confounding factors in equal numbers into the 2 groups. And if there's no evidence of effect, don't treat. It's a very valid approach. It's one which I think is mainly in use in the UK, but also in use in other places around the world. Okay? No evidence, don't treat. But let me just say, no evidence of effect does not mean evidence of no effect. Absence of effect does not mean effect of absence. Is that correct? Is that correct English? Am I forgetting my language? Anyway, another approach, which I will call personalised, even though it's not strictly personalised, is that the patient has autonomy and the right to choose. Their views are valid, not only the physician's views. And we have to reach an accurate diagnosis by ruling out the confounding factors, not by randomizing them, and determine which patients will respond and which patients will not. That is, genetic tests, embryoscopy, karyotype the embryo, do paraffin block analyses on previous miscarriages, and take those that are a clean group, if homogeneous, please. Ignore the word clean, I should not have said that, okay? Of patients who only have non-genetic and non-structural anomalies, and then do the study on those patients. Use what we call restriction. Also, a very valid approach. So, let us close with this stalk. Now, those of you who know me know that I do not believe in IVF. I hope I'm not offending any IVF people sitting here. I believe in the stalk. Don't we all know that the stalk brings the baby? Andrea, doesn't all the evidence say that? Well, anyway, the stalk has to remember a number of facts if she wants to go through. First of all, progesterone developed millions of years before pregnancy evolved. It's an anti-inflammatory hormone which mammals adapted for viviparity. It supports pregnancy by anti-inflammatory cytokine effects as well as the endocrine effects. The results of all of the studies that we look for and call evidence may be confounded by fetal factors or overwhelming of the immune response. Progestogens may prevent miscarriage of a viable embryo, not of a non-viable embryo. Dydrogesterone has advantages over progesterone itself in terms of efficacy and side effects. Thank you very much for inviting me. I want to thank the Abbott Company for inviting me, and to the organisers of having brought the stork to Rome, where the stork will fly off to next, God only knows. Thank you.